Yeah? Get comfortable because you'll all be in here after Thursday. You'll all be sitting in these chairs. One thing at a time? Well, Thursday, is it Thursday like the next thing at a time? Okay, I'm like, what's one thing at a time? That's Thursday.
We'll get you into this class first.
Yeah. Oh, gotcha. Thursday first, then move in? Okay, all right, track. Okay. So, welcome, everyone. Thanks for joining me today. Yeah. So, a couple of things, okay? So, I know everybody's freaking out about this exam. Very well aware. Everybody's freaking out about this exam. Why are you freaking out about it? You're freaking out about it because you play the rumor mill with the other classes and, you know, all that kind of stuff, right? Let me give you a little bit of history on this block 2 since I took over radiology. The people who are not seniors, because they went to phase 2, so not the current seniors in the class ahead of them, okay? 0 people recycle because of radiology. 0. The current seniors, 1 person recycled because of radiology. Okay, this is not like a 4 or 5 recycling type course. The people that don't do well on block 2 do a couple of things. It's going to be unique because I've never been the last test of this semester, so I'm actually really excited to see how you guys do because you've had like a week of dedicated radiology time, and that usually doesn't happen. It's usually in the middle of the semester, sandwiched between like a farm and an ENT test or something like that, right? For my block 2. So I'm really intrigued to see this, but remember the things I've told you the entire time through block 2. Please, 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 please read the question and the answers first. And here's why. Starting with this test and going into junior semester when you're in this class, your days of having a lot of questions to where you read it and you're like, this is the definitive answer, that's almost over. You'll still have some. But a lot of times now you're going to have 2 or 3 choices that could possibly be correct, and you're trying to figure out what's the most likely answer or the most correct answer with the information that's presented, because that's medicine. Very rarely you're going to have a patient walk into your clinic and they're going to walk out and you'll be like, I know this is what you have. Right? It could be 1 of 3 or 4 different things, but based off the information I have now, this is the most likely thing that it can be, so we're going to act on that. And then if it doesn't get better, you follow up and then we adjust to a different diagnosis or a different plan of care. That's what the classes in this room are all about next semester, right? So, with this test in particular, we don't talk about treatments or anything like that, right? It's all about trying to find what we think is going on or recognize an abnormality on a film. So if you read the question and the answers first, you already know what I'm gearing you towards. Before you look at an x-ray that may have 4 or 5 different things going on with it, you spend all this time trying to figure it out, and then you find out that my question is like, what is this? And you're like, dang, I just went through like CHF and left atrial enlargement, come to find out, he just wanted me to know that that was a claustrophrenic angle, right? Read the question and answers first. Furthermore on that, how many of these things are really similar, right? A lot of these things are similar. So if you read the answers first, you'll know if I'm trying to have you pick out a cardiomyopathy versus a pneumopericardial or a pneumomediastinum, or if I'm just asking you about parabronchial cuffing versus cephalization versus uncoiling the aorta, right? So you'll already know what you're looking for before you go into the vignette and the picture if you do it that way. And in clinic, that's really how it's going to be. Because when you send somebody for imaging, hopefully, you're not just, pow, 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 I'm going to do it because I don't know what's going on. You have an idea what it could be, and the image is supposed to help you narrow that down, right? So look at your answer choices first, and that will help you in a time management standpoint. Pathophys. If you understand the pathophys of things, if you understand the flow of these abnormalities, right? i.e. hypertensive cardiovascular disorder. What enlarges? Why is that enlarging? Because of what's happening in the body versus pulmonary arterial hypertension or that mitral stenosis. Why does that happen? Why does the left atrium get big because of that? Because of where the backup is. What part is working harder? It will help you significantly when you're trying to decide between these things because you'll know what's supposed to be big, what's not supposed to be big versus the patient's symptoms and all of that stuff. So understanding pathophys will help you a lot on this one as well. So I know everything looks the same. I know it does. A lot of things look the same. but if you put everything together, it's going to be okay. If there are still confusing points, that's what I'm here to kind of clear up. All right? But take a deep breath. Please read the question and answers first. Please. I promise you it'll save you a lot of headache. A lot of headache. Questions on that so far? Okay. Yeah, same rules as the test from last time, right? You'll be able to zoom in and out if you want to. I got news for you. If you're zooming in so far, like, what is it? You're zooming in too far. You're in the weeds, right? Nothing in there is going to be so small and minute that you really need to be like, is that a little line that's fuzzy? I'm not sure. Not here for that, right? That's way too in-depth what you guys need to know. So if you're doing that, take a step back and go back and 20,000 foot view and figure out what I'm trying to have you find. All right, what are my confusing topics? What are my questions? What do you guys got? Sometimes I'll pull the slide up if I need to, or we'll just talk about it. Sir?
So on mitral stenosis, you're saying how the atrium, so you have the atrium and the ventricles, the atrium can get bigger, but then also can the ventricle get bigger if it's left for a long time?
So, well, it depends, right? So think about the pathophys of that, right? The mitral valve stenosis. Let me see if I can find that. Does anybody know offhand what lecture that was?
Second.
Thank you.
Slide 36.
Oh, look at you.
One down.
Thank you. This is because I'm not used to this podium. It went big, but then, what does that say? Just hit enter. Ha! Just hit enter, see what happens. Okay, so, yes, but which ventricle?
Right.
Can I see that on a PA? Sure as heck can't, right? So thinking, and that's why I say like the pathophys really helps you understand what's going on. If my mitral valve stenosis is happening, that's going to lead to left atrial enlargement. Why does it lead to left atrial enlargement? Where is my mitral valve? So where is the blockage or the stenosing, right? The stiffening, it's not working well. So it's that left atrium that's right before it. So that's backing up, that's trying to squeeze through. It's working harder to try to squeeze through the mitral valve because it's stenosed, so it can't, so it gets larger. On top of that, that continues to back up. Back up where? Back up into the lungs, right? Because that's the pulmonary artery that kind of comes into there. Continues to back up, going to that right ventricle, which is pushing things out, and that's why the right ventricle gets enlarged, leading all the way back to that pulmonary arterial hypertension, right? It's all one big pathophysiology flow, whereas your left ventricle enlargement is due to hypertension. Why? It's the left ventricle that is pushing the blood out into the aortic arch, the oxygenated blood to go into the rest of the body, right? And so this kind of goes to that point that I was just saying, understanding what the abnormality is and how things flow and what happens, it will help you kind of trigger like what do I expect to see from an enlargement standpoint based off of the abnormality I'm concerned about. Does that answer your question?
Yeah.
Yeah. So the ventricle does get enlarged, but it's the right one, which we would only see that on what image? The lateral. We will not see that ventricle enlargement on the PA. So if you have an enlarged left atrium on the PA, you may or may not have right ventricle enlargement, right? How far gone is it? I don't know. We may not have even that enlarged pulmonary artery yet, because that first step through that mitral valve stenosis is going to be the left atrial enlargement, because that's the closest to the issue at hand. So that will enlarge first, and then it will lead to other things. Does that answer your question?
Yeah, it does.
Okay.
Kind of segued into like the aortic stenosis, which would be going into the arch. So.
Correct. So that's where that left ventricle comes into play. And the keys distinguishing people be like, well, what do I have? Aortic stenosis, left ventricular hypertrophy. Well, crud, is that hypertensive cardiovascular disorder? Is that aortic stenosis? What does hypertension cardiovascular disease not have? A murmur. A murmur, right? If you just truly have hypertension, there's no murmurs with hypertension. Not your standard just hypertensive cardiovascular disease, but aortic stenosis has a murmur, which is why that new murmur with maybe left ventricular hypertrophy or maybe even hypertension with a murmur, we're thinking aortic stenosis until proven otherwise. Whereas if there's no murmur, right? And so that's when we get into, like, if you were to have a question or an image, or even in clinic, you have a patient with this kind of stuff, and you're like, hey, what could this be? It could be aortic stenosis or hypertension, long-standing hypertensive cardiovascular disease. How do I know? Well, is there a murmur or not? That's going to make one much more likely than the other, and that's where we would go with our diagnosis on that. Clear as mud? Yeah.
Kind of in the same line. So, for pulmonary arterial hypertension,
Yes.
It was like one of the main causes of it, or secondary causes of it, was mitral valve stenosis.
Yes.
So, I'm just trying. I was going through everything and having a little bit of trouble, like finding they have different imaging to them, like related to what's the most important thing, like
Yeah.
what's kind of like the key things that we should be taking away, that, like, to differentiate between the two.
Between which two? I want to make sure I answer your question clearly.
So when it's mitral stenosis, like is the early symptoms of mitral stenosis kind of like what gives us that, versus like when it backs up and then causes the hypertension?
So mitral stenosis will typically, if we're talking just in relationship of mitral stenosis to pulmonary arterial hypertension, the stenosis will happen first.
Okay.
And then as it gets worse and backs up, eventually you will get that pulmonary arterial hypertension, that widening of the pulmonary artery, and mostly hard to see on x-ray. So what imaging do we see that on? CT. And when you're looking at the CT, which two things are you comparing to figure out if this is a true pulmonary arterial hypertension patient? The aorta, the diameter of the aorta, and the diameter of that pulmonary artery. If the pulmonary artery is wider than the aorta, and in this case it's the ascending aorta with where they're sitting, right? If it's wider than that ascending aorta, that's enough to diagnose pulmonary arterial hypertension. Now you're going to learn in pulm how to truly diagnose without having to get a CT with like the capillary wedge pressure and all that jazz, right? But you'll learn that in this room. But for me, for imaging, if you're trying to diagnose that, is that pulmonary artery wider than the aorta at that point of diameter width?
Try.
Okay, does that answer your question?
Mostly, yes.
Mostly. What part am I missing?
Just the curiosity with the mitral stenosis, can that cause what? So it can cause pulmonary arterial
Correct.
hypertension. How far along would they have to be for that to really?
Not important for this course.
Okay.
Really
I
nice.
was like,
Not important. I love that you're thinking like that, right? And that's a really great question when you guys get more into the weeds of the pathophys and the stuff in pulmonology, right? And you start understanding that on a deeper level. But for this course, not important, because I want you to save the brain cells for what's going to benefit you guys on Thursday. And that's the challenge with this block, is teaching you guys just enough pathophys to make you understand it, but not too much to get you guys all muddy, because you're going to get plenty more next semester in cardio and pulm and endo and all that stuff. All right, what else? Yeah. Yeah, so it's just, let me see. See if I have, I think that, is that it? Yeah. Which one? 36 again? Okay, thank you. It's weird, I'm not used to this thing. I normally have it right here and I don't, so. But I'm looking at what you guys are looking at too, I think, so. All right, so what we're looking at here, let's focus on the light, that should work. Okay, let's focus on the normal x-ray, okay? The normal one over here. I want you to take a look and kind of see how we have our vasculature markings, right? We got our hilar region, and we got the pulmonary vasculature kind of comes out, how you can trace almost everything out like a tree branch kind of coming all the way across, right? When we're dealing with the pulmonary arterial hypertension, we got a couple of things going on. First, I have my enlarged left atrium. That's the red arrow, okay? Sign number, let's say you don't have the CT. There's a CT we're talking about. Let's say you don't have that. I have my enlarged left atrium, right? And so now I'm looking at this enlarged left atrium like, okay, well, dang, I've looked at a lot of x-rays. Is that a left atrium? Is that a descending aorta? Is it the start of an aneurysm? Like, what the heck is going on here? I don't know, right? So there are two things you can try to look at to figure that out. So I got my enlarged left atrium. Well, one, here's my aortic root, my aortic knob. So that's definitely not going to be the aorta because I can see a very clear aortic knob. So that's step one to go, that's probably the left atrium. So now I'm thinking maybe this is pulmonary arterial hypertension. To be honest, or mitral valve stenosis, depending on what I'm asking, right? Because they're kind of one and the same. So I wouldn't have, with just this x-ray, both of those as choices, right? Because one leads to the other. Wouldn't necessarily have that. But then my next question becomes, okay, so I'm pretty confident that I have left atrial enlargement here, and based off of the question and the answers that I already read, before I got to the picture, because I already read those answers, I know that that's one of my possibilities. Now, if there's nothing else in here that can do that, maybe I'm like, okay, maybe that's enough. Maybe I can answer the question now, right? But if I'm still concerned, then I can jump to that pruning standpoint to see if that's there. What the pruning is, again, in comparison to my normal, is I have my vasculature, but where are my tree branches? It's almost like we cut off those tiny little branches, and I just have the bigger branch, and we cut off all the little twigs. That's kind of what the pruning is. Whereas on my normal, I got all my little twigs coming out here. But when I get my pulmonary, and the reason for that is because the pulmonary artery is getting larger because of the hypertension. Those other vessels are backing up and getting a little bit larger, and so the density difference, you can't see those fine kind of little vasculature areas or twigs, as we're calling them right now, off of the edge, and that's what's creating the pruning. Does that answer the pruning question, like kind of how we're looking at that and why we're seeing it, right?
Yeah.
Okay. So it's all kind of in conjunction with one another. Is there a lot more going on in this x-ray than what I just showed you? Yes, there is. But if I ask you a pulmonary arterial hypertension question or a mitral valve stenosis question, do you care about all these other things if you found the answer? No. Read the question and the answers first. Okay. What else? I know there's got to be more confusing topics. Yeah?
Do you ever like visually identifying distinctly cavitation? Just feel like the image of cavitation seemed kind of similar to other things.
So partially situational here, but really similar. So I guess to help me out, in order for me to kind of help distinguish it for you better, what are the things you were feeling like it was similar to?
Just really like any ear space. Because I know it didn't seem like it was super isolated to one lobe.
Correct.
But that commonly seen in reactivation of TV.
Sure.
But other than that, it kind of looks similar to some of the other STD.
Okay. So think of cavitation as this, right? And when you're looking at things, so I can understand a lot of these abnormalities are kind of similar. There's very few of them that have been circular in nature, right? Like an actual, like no joke, like circle. Okay, cavitaries is one of them. There were a couple that were the masses, but those were all like solid filled. They didn't have like a regular lung-looking kind of hollow fill to it. So think circular in nature. So when we talk about those things that are shaped in a circle, not shaped along the thorax wall like our normal thorax, right? Actual, like somebody took a circle of something and stuck it in the lungs. The next question becomes, is there fluid or not? So our cysts are going to have fluid, air fluid level, that nice flat line to where I kind of see the circle and then I have that flat line. So that's how I can distinguish between cavity and cyst, is do I have air fluid level? And then the other ones would be like those blebs or those bullae that we talked about. And that's just going to be the thinness versus the thickness of that cavitary wall. Right? When you look at that circle, there was a nice, thick, kind of outer layer to it. You could almost take like a thick Sharpie and kind of circle it and draw it and stay just on those walls. Right? And so if I have that radio opaque, and if you know this, let me try to find the slide. Cavitary lesion. This one might be it. Thorax, clinically. That's the carcinomas. Really should make a cheat sheet for these things. There we go, perfect. 70? Appreciate you. Can't be 70, there's only 60 slides. Deck 3 again? You lied to me. Okay. So we're looking at the cavity, right? Look how thick. First of all, here's my circle. I can trace a nice little circle in here. Nice little circle. On the inside, I have a darker, more radiolucent area. So this is not a mass to me. If this was like a cancer or a mass, this whole thing would be radiopaque, right? If it was an adenocarcinoma or something like that, all of this would be radiopaque. If it was a cyst, somewhere in here I would have this nice, clear, horizontal line filled with fluid, and that would tell me that it's probably a cyst as opposed to a cavity. And then the thickness of this is really the biggest thing of noticing the cavity over, say, the bullae or the cyst or something along those lines. So it's the lack of air fluid levels and then the thickness of that wall. And the thickness is probably the biggest factor. Does that help?
It does.
Okay. Sometimes it's just finding the right way to kind of say it and kind of describe it. It doesn't always get across in lecture, which is why I like to do this. What else we got? Yes, ma'am. Was.
For the anterior mass,
Yeah, so remember how confusing those were, and that was why I said there will not be a question of distinguishing between lymphoma and lymphadenopathy on this test, because I need to make those slides more clear going forward, because that was confusing. Yeah, so do not know so for the mediastinal masses, don't worry about most common or anything along those lines. There's that one slide with the chart which tells you which masses are where, right? And posterior had one, yeah, posterior had one, anterior had one, middle had all the other ones, right? Know that, which if you know posterior and you know anterior, then anything else has to be middle for right now, and know that. I'm not going to get into the lymphoma versus lymphadenopathy because of the fact that that was very confusing, and I need to fix that going forward. What else? You guys got some good questions. I like this. Yes?
Sure. Can you just distinguishing like lobular versus like double pneumonia as far as like the lobular, you're going to see air bronchograms because it's not being the actual air space.
And that's what you're kind of looking at, right? Yes, when you have the lobular pneumonia, it's within the entire lobe, and that's going to give you that air bronchogram because it's basically sitting in throughout the lobe, so that airway kind of stands out more. And that's going to be your difference primarily of that's your lobular pneumonias, right? Is seeing air bronchogram or not.
And the infection then just be like the surrounding tissue. It's not like, I just like when I think of pneumonia, like fluid in the lungs and that sort of.
Correct. And so the fluid in the lungs from the pneumonia is just from the inflammation, right? And so yes, pneumonia always has fluid in the lungs. It's just a question of where is that fluid. So then what type of pneumonia is it? So you're right, it is a fluid in the lungs kind of thing. But in the lobular, it's fluid throughout the entire lobe, not just in the alveolar airspace, not just in maybe like the interstitium area. It's within the lobe, which is what makes that lobular pneumonia. And that's why we get that air bronchogram. So you're right, that is what a pneumonia is. And then the descriptors are just where is that fluid based off of what I'm seeing on the picture.
So that's more like in the interstitial space. It's not like in the actual airway. It's like in the surrounding.
Correct. Correct. It's not in the alveolar sacs or anything like that yet. It's just throughout the entire lobe. Yes, ma'am.
For an X-ray, are we going to need to know how to differentiate between subpulmonary fusion and just regular pleural fusion?
No. I need you to know what pleural fusion is. I need you to know the details of pleural fusion, pull those things out, know the definition of fusion in general, right? But no, I'm not going to make you distinguish between actual generalized pleural effusion and a subpulmonary one. No. Yes, ma'am.
When it comes to organomegaly,
Yes.
for the liver,
Yes.
there's a normal variant.
Yes.
The RADS lobe.
Yes.
Is that considered enlarged or is it just normal?
Yes. yes it is. So actually it's a really good one. Somebody had a question for me about this earlier today. Rydell lobe is still hepatomegaly. The liver is still enlarged. Hepatomegaly is enlarged liver, period. End of discussion, don't care why. Why do I tell you about the Rydell lobe? Because when you're getting imaging on a patient for whatever reason, and you have an incidental finding of hepatomegaly, let's say you weren't even looking for the liver, but you got the x-ray and now you see this huge liver. What, are you gonna do something about it? We don't know yet. We gotta figure out why they're having that enlarged liver, right? You have to investigate it further because now you have hepatomegaly that the patient didn't know beforehand that they had, so you have to investigate to find out the cause, right? You'll learn later on how to investigate that. It involves an ultrasound, try it in labs, all that stuff to try to really rule stuff out. Rule out cirrhosis, rule out fatty liver disease, X, Y, and Z, and all these things. You're going to get a report that comes back on some imaging that says that enlarged liver is a Rydell lobe. I tell you that that's a normal variant, so you know once you have that information, you're done. You don't have to do any further workup. This patient's not sick. This is a normal variant for them. They're going to have hepatomegaly for the rest of their lives. That's a definition of enlarged liver. But the Rydell lobe is a normal variant. They're not diseased. They're not sick. There's no treatment that's needed. There's nothing you have to do for that patient. And that's kind of why I have that in there. So that way you know that that patient is okay. But it is still considered hepatomegaly because it is still an enlarged liver. It's just a normal variant that makes it enlarged.
Do they have increased liver function because of the size of the liver and it's normal?
I don't think so. Like their liver function test should still be the same in that aspect. So I don't think it has any effect on the LFT. I don't know for sure, but I've never seen one. Yeah, super processor, right? Does that answer your question? Mm-hmm. Okay. So yes, it is still anything that, and same with cardiomegaly, right? Cardiomegaly is just an enlarged heart. It's not a diagnosis, right? It's an abnormality, and then the next step becomes, why do they have cardiomegaly? What's going on? Is it hypertensive cardiovascular disease? Is it pericarditis? Is it a pericardial effusion? Is it a cardiomyopathy? I don't know. You guys are going to have to do that workup when you get out to clinic to figure that out. So it's just a definition of it's enlarged, and now why is it enlarged? Good stuff. Yes, ma'am.
Sir, can we go to deck 7, slide 73?
Slide 7.
Sorry, deck 7, slide 73.
73. Okay. Deck 7. This one?
Yes, sir. So at first glance, to me, like it looks like there's a significant difference between the right ureter and the left. It looks smaller, maybe obstructed. It's listed as a normal study.
Yes.
How do we differentiate this from an actual pathology of that ureter?
Yeah, excellent question. So what is this study used to check for? Specifically? Flow, because we're looking for concerns of what? An obstructing kidney stone or ureteral stone, right? I don't care with this study because I can't tell if there's a defect in the ureter itself. I don't know that. I can't see the ureters. I see the contrast in there, right? So how do I know? So they're going to look a little bit different depending on how they're lying in the body, right? It's because ureters are not like perfect, anatomy like any of our stuff has been. So that's okay. So how do I distinguish that it's a normal study? Well, first, my calyces and my pelvis are fairly normal size, so I don't have hydronephrosis there, right? I don't have these huge enlarged kind of calyces and pelvis. So that tells me, okay, maybe not obstructing for sure. And then what I'm doing is I'm looking at a couple of things. I'm following down, and it's kind of hard to see here. But what I do is I have contrast, and then I also have contrast spilling into the bladder at the bottom parts of the ureters on both sides. Which means if I have a kidney stone, it's not obstructing. That's how I know it's a normal study. I have flow coming through without any backup and without any hydronephrosis. And then I can see it coming down into the bladder and filling the bladder on both sides. Do they have a kidney stone? Maybe, but it's not obstructing. So this would be a normal IVP study, right? And so when are we doing these? Again, when I have nothing better to use, because a CT non-con is still the best study to check for kidney stones, because that's not only going to tell me if there is one, but it'll tell me the size and all of that stuff. But what you can safely say from this IVP, if it looks like a kidney stone, it smells like a kidney stone, you're pretty sure it's a kidney stone, and you get this and you see flow in both areas, You can give them some Flomax, some pain meds, and say, hey, that kidney stone's going to come out here soon because it's not obstructing, because I can see that flow, and that's what the intent is for this. Do I have an obstructing stone that needs to be further evaluated for removal? Does that answer your question? Perfect. Good stuff. What else? Sir?
So going to the same deck as the ovarian cord.
Yes.
So Doppler is always your initial, and then the CT abdomen is your study of choice.
Yeah, so it's a female pelvic organ, right? Reproductive organ, so it is Doppler. 100% it is Doppler, okay? If Doppler is normal, ultrasound is normal, but you are convinced that this patient has a torsed ovary, like they have the symptoms, they look like it, they feel like, you're like, this might be a torsed ovary, but my Doppler is normal, then you're gonna get the CT, right? Because the risk of the radiation at that point versus the risk of a torsed ovary that doesn't get corrected is much less. It's very rare that you're going to have to jump to that because most of these Dopplers are going to be abnormal when they have a torsed ovary. That's just more of a cautionary, like, please do not make the ultrasound be the end-all be-all, because the difference between that and testicles is you can visually see the testicles if they're torsed or not. Like, you can see what that looks like. So you get the ultrasound to see how severe it is, but you can see it. You can't see the ovary. So we have to jump to CT if we still suspect an ovarian torsion, even though my Doppler is normal. But my Doppler ultrasound is always going to be the one we're going to use to evaluate that. What else? Yeah.
So I guess kind of like this question, so if we're getting ultrasound, but then that comes up into the HSG.
Correct. Because you're doing the retrograde, because there is no ultrasound that I can see the fallopian tubes, right? That is like, I think that was the only reproductive study that was not ultrasound on females, and it's because I can't see it. I mean, you saw the ultrasound when we looked at like the uterus picture. All it really kind of has is just the muscle of the uterus folding over on itself. You can't really see the fallopian tubes or the patency of the fallopian tubes, and that's really what it is, right? I'm not evaluating whether or not the patient has fallopian tubes. I'm trying to figure out if they're patent or not. And so the HSG is going to be your fallopian tube study to check for patency or any structural abnormalities within that. It's not a uterine study, right? Yeah, we put the contrast up into the uterus, but it's to go up into the fallopian tubes and spill out into the abdomen. Hysterosalpingogram. What else?
So we also went into like the ultrasound of the heart, the pericardial effusion. Like there's like a page on there where it has like ultrasound.
As part of the FAST exam, yeah.
Are we need to be very familiar with that, how that looks, like to be able to pull that out?
Probably.
Yeah, I don't know.
Maybe.
Kind of reference.
Maybe. We went over FAST exam quite a bit, and actually in this block, we actually took the time to look at each area of the FAST exam and what an abnormal looked like. And everybody in this room will be doing their own FAST exams in their clinic if and when needed. So I would venture to say that it's probably important to know what an abnormal FAST exam looks like on any of those images.
So we're gonna have more than just X-ray images on this test?
Yes, anything that we've covered in this block is like CT, X-ray, or ultrasound, right? Still no MRIs, not making you read MRIs, and really from an ultrasound standpoint, guys, it's going to be FAST exam stuff just like it would have been on the first one, right? You guys are not going to be ultrasound techs. You know, I focus on the ultrasound abnormalities that you might be doing in clinic yourself, which is pretty much that FAST exam, or looking at an ultrasound and determining the, kind of like the first block, right? We had that hyperechoic, hypoechoic, that kind of thing. So anything that's in the slides that's not MRIs really is going to be okay. But yeah, there'll be X-rays. I think there's even some CT images on this one, and there are a few ultrasound images as well. But no MRI, no nuclear medicine study. I don't think. No. What else? 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 What Unless it was the basic ones we covered, right? The thyroid ones, the PE ones, the ventilation perfusion scan, like those ones. But nothing like, I'm not going to give you like a PET scan and tell me like which one is cancer, which one is just inflammation. We're not getting into those weeds. Ma'am?
Can we go to deck 4?
Yeah?
Slide 26 or 30?
You said 26 or 30?
Yeah.
Okay. Deck 4.
Could you point out what I'm supposed to be looking at here? The abnormality of mine.
Point it all out. Yeah.
I just don't
White
know.
arrows.
I don't know if I know.
Alright, so this one's tough, right? Because it's hard to find a normal to be able to compare with this to get just the right slice, because if I were to try to give you a normal on this one, the patient anatomy or slice might be just a little bit different, so it's not a fair like apples to apples comparison. They go, hey, here's what the normal looks like. See this abnormal, so it's really hard to do that like a specific CT slice. But what you're looking at here is everything in the white, right? The radiopaque, the white. This is your pulmonary vasculature. So this is a CT with contrast. It's a coronal slice. So the contrast is in the vessels and it's showing that. What the white arrows are showing is this. So first of all, regular lung tissue, right, out here. So regular lung tissue. I can kind of see my small vessels, but I can see like the tissue that's sitting in there. It's like a grayish. It's not pure black, right? So if I go down underneath here, these dotted white arrows, I see pure black. So that's my air that's sitting in there, right? And then what you're looking at around the vessels here is those linear black streaks and lines around the white vessels. It's not grayish, right? That is just pure black. That is air that is within the interstitium. So it's the pulmonary interstitial emphysema. So likely what happened here is there were some blebs or something along those lines that kind of burst, causing air around the vasculature in the interstitium of the pulmonary tissue, and emphysema means air. So that's showing you that there's air around those vessels. That's your pulmonary interstitial emphysema. Oftentimes this will end up leading to a pneumomediastinum because it's close by, so it penetrates into there. Maybe a pneumopericardium, maybe a pneumothorax, maybe there could be all kinds of stuff. That air is going to go somewhere. But you can't see this on x-ray. This is not visible on x-ray. It's too finite. There's too much stuff in there, too much vessels, tissue. It's going to hide. The only way we can see it is on CT. So a lot of times you'll end up seeing this if you have a patient who has a pneumothorax and you're not really sure why. And you're trying to figure out what the cause of it was, or there's something else going on, so they end up getting a CT and then you end up finding it. Very rarely are you jumping to a CT, like a patient's going to come in and you're like, I think we have pulmonary interstitial emphysema, let's get a CT. It's usually found in conjunction of further evaluation on a patient that has some kind of pneumomediastinum, pneumopericardium, pneumothorax, something along those lines, as you're continuing to do more workup to figure out why. Especially if they're not trauma, right? There's no trauma for this patient. There's no explanation for their pneumothorax. Maybe if they're a young, tall, thin man, maybe it's a spontaneous pneumo, you're fine. But if it's like an older person or somebody that doesn't match up with that, you're trying to figure out why the heck do you have this pneumomediastinum or this pneumothorax, and I have no trauma or no other explanation for it. You're probably eventually going to go to a CT, and that's what you're going to end up seeing. Does it stand out for you now? Mm-hmm. Okay. Yes? Here? This here? This is the heart. Aortic knob, right? So this is a giant pleural effusion, and so it's pushing the entire mediastinum over. All of that pressure from this fluid is pushing the mediastinum over. So this is heart. Here's your aortic knob. It should be sitting right here. I can see the whole knob. I should just see a little bit. Because it sits kind of behind the spine, you see that little bird, right? But when I have all this fluid filled up, it pushes it over. Same thing here with this giant pneumothorax. It's pushing everything over because of the pressure of the air and the fluid, right? So aortic knob here, this is the main heart. All this fluid is pushing everything over this way. And you can see that too with your trachea, right? And your bronchus, everything is coming over. So that's why it looks like that.
And one more question.
Yeah.
Because this one is tensionless for us, right?
Correct.
Okay. And then tensionless thorax, we diagnose it clinically.
Yes.
Can you go over like how we do that, or like?
Yeah. They have a pneumothorax and they're unstable.
And by unstable, we need vital signs.
Correct. Vital signs, or something in the vignette is telling you that they are tanking, they are unstable, right? They are decompensating is another word that could be used, right? So in clinic, it's a lot easier. If I'm writing a vignette, I have to give you something that tells you they're stable versus unstable. I could just say it, or there could just be vitals that tell you that they're unstable versus stable, or use other words too, like the patient is decompensating or something along those lines. Correct, because you don't have the patient in front of you, so you would have to explain it somehow that they were stable versus unstable. If I wanted you to distinguish between tension pneumothorax or regular, unless, right, if I have shifting, you don't need vitals on this one to tell me it's a tension, right? Because the mediastinum has shifted. I have a tension pneumothorax. Tension is being caused by pushing it over. You don't need vitals on that. But if you have a pneumothorax without mediastinal shift, your vitals will tell you whether it's tension or not. Right? But if I see this, even if they're stable, they're not going to be for long, so we treat it like a tension.
Even if you stable, you still too.
Yes.
That one. So this one got me on the last exam, so I was curious. So there's like an algorithm.
Yes.
So the patient comes in, I suspect minimum, but he's like vitals are saying it's unstable. Would my first go-to be like EFAS, like ultrasound, and maybe a chest X-ray, because it says he still has like chest X-ray like initial. But with an unstable patient, would it jump to EFAS?
So you're confusing your algorithm for EFAS versus what modality of imaging? CT. Never have we adjusted EFAS for X-ray for stable versus unstable. Why do we decide between stable and unstable for EFAS versus CT? People die in CT. I don't want to send them to another department. Do I have to send them to another department to get an X-ray? No. How quickly can a chest X-ray be done? Like that. So there is no distinguishment. We're still getting a chest X-ray, right? Still getting a chest. I like your thoughts. So in reality, you have a trauma patient coming in, and you're like, I don't know what's going on. You're doing the EFAS while they're getting the chest X-ray, right? In a real world scenario, that's happening simultaneously in that aspect. So if you suspect pneumo and they're not stable, right? What does suspect mean? Just because you think so? Or did you do physical exam findings and you have absence of lung sounds? That's a little bit of a different story, but you'll get into that treatment kind of in pulmonology. But for any of my pneumo questions, it's either going to be straightforward where I say, hey, they have a pneumothorax, here are their vitals, what are you going to do next? Or not really going to need to talk about treatment, but like how do you diagnose it? Or it's going to be based off of a picture with a vignette and you got to distinguish between what's going on. But yes, EVAS versus CT, not X-ray. What else? You guys got a pretty good grasp on this stuff. I like you got some really good questions. What's up?
If you see a pneumogenous item, is it correct to assume that you look for the pneumopericardium and pneumothorax? Is it like a progressive thing that you know?
Good question. Depends. It's not a linear kind of pathway in that aspect. It's a maybe. So if I see pneumomediastinum, right? Remember, pneumomediastinum is the pneumopericardium and the great vessels. So once it goes above that, it's just a pneumomediastinum. So right, if I have a pneumomediastinum, you can assume there's air in the pericardium as well, because it's the whole thing. It's the whole thing. Pneumopericardium is by itself, and then once it gets above those great vessels, it just becomes a mediastinum. It's one or the other. It's not necessarily both. Does that make sense? As far as the pneumothorax goes, maybe, maybe not sure. Because I could have subcutaneous emphysema and it just be within the mediastinum and it kind of came out that way, but I have no pneumothorax. But I promise you, if I see a pneumomediastinum or a pneumopericardium on an x-ray, I'm looking harder for a pneumothorax just to make sure. So some have and some don't. What? Go ahead.
To jump on that, so with the mediastinum, are we always going to have this subcutaneous?
It's not always going to be there, but I would definitely look for it. Because a lot of the times it is, because that air's got to go somewhere. So it's not, it's right, as you're going to hear this, especially going into like your junior and senior semester, right? You're going to ask a lot of those kinds of questions. They're going to go, that depends. Right, Captain? Yep, see? It depends, right? There's not a whole lot of definitive. There's a lot of most likelies, right? And so, yes, I would look, and I would use that more as a, listen, if you get really good at reading this stuff, you're like, bam, this is a pneumomediastinum. I don't care about the subacute emphysema. You diagnose a pneumomediastinum. But if you're on the fence, I would use that subacute emphysema to either increase your suspicion to look again or go, well, maybe there's not one there. Because if you have subacute emphysema and it's not in the, not in the presence of like a direct trauma to that area that would have introduced air to that area, then I'm thinking there's probably a pneumomediastinum there because I see that. So do it more in that direction as opposed to I see a pneumomediastinum. I'm going to evaluate for the subacute emphysema, but if it's not there, I'm not too worried about it because I just diagnosed this based off of what I know. It's more kind of to help you out the other way around. Why don't you guys take 5, take a quick bio break, kind of gather your thoughts, and then we'll come back and we'll do any more questions, all right? And again, right, I just kind of shifted this kind of a review, so I'd love some feedback, like, is this better than just going through those blue slides and just be like, what is this, what is this, what is this, right? If not, that's fine. Tell me when you do the end of course thing, end of course critique, please let me know if you preferred this type of review or if you just would have liked me to pull up the blue slideshow and just do like pop quiz of stuff, right? I'd like to know that because it used to be that way, and I just felt that from feedback on those things was like, hey, it would be nice if like we could focus in on things that we're confused about as opposed to already knowing what color this is on x-ray or whatever those review slideshows say, right? So I'm open to adjusting things. So please put that in your free text a little bit and then tell me how terrible I am at other things. Right? It's the only way I get better. Yeah, that's both is fine too. I can take it. I'm from Chicago. It ain't gonna hurt my feelings. I want to make it better for you guys, right? That's the whole goal here. All right, what else do we have? What other questions do we have? Ma'am? Sure. 16. Yeah. The other red slide. That red slide. Yeah. It is. It is the wall of the bullet. Yes. So you are seeing multiple. Here's another line here. There's one here. There's one here. This one is kind of like right in here. So yes, these are the walls of multiple bullae within the same lung. So for this thing. Sorry, this is where he's recording, so I just want to. These are the walls of the multiple bullae. Go ahead.
I thought bullies were only filled with air, but this one, I've had a you can still see like the lung.
So you can a little bit because they're a little bit smaller, right? But look at this main top one. There's pretty much no vasculature sitting in here, right? So the biggest one doesn't have any vasculature. And you can still see some of the lung tissue and the vasculature in these smaller ones, right? So the bigger they get, the more radiolucent they're going to be, right? They got to start at a certain size, and then as they get larger, that will thin out more, and that's where we get the radiolucent one. So when we're in our bullae presentation, right, we have a lot of the really big ones to kind of show you what it looks like. But the key thing to take away from this slide is not necessarily, hey, are these bullae or not, because this one, sure, is don't let this fool you from a pneumothorax. And how do we know that? It's the direction of the radio-opaque line. Because the pneumothoraces follow the wall of the thorax. And because we loop down here and kind of do it this way, and we got all these little kind of edges and kind of circular patterns, this is not a pneumothorax. What was your question?
Because there's no vasculature in the area, how would we classify that as a bullae versus a Western mark sign?
Oh, Don't worry about the Western Mark side. Yeah, don't. Know what it is. Know what it means if there is one. But like I said back in the lecture, when it comes to the Western Mark side, right, and those PE X-ray findings, I'm not going to make you pull those out on X-ray because A, they're a late finding and they're super hard to find, and very rarely do you find them. So you need to know what they indicate. But I will not be giving you an image and asking you to pull out a Western Mark side. Yeah, thanks for asking that. Yeah, I want to make sure that's very clear. Or a Hampton's hump, right? That was the other one. Not going to make you have to pull that out on an image. Know what it is, in case it's in like a radiology report. You're like, oh, that's not good. I need to do this now, right? But, nope. Bam.
CTFPs will be given the Wells score for like the criteria of which way to go.
No. Because we did not really cover Wells criteria and how to calculate it. You will in cardiology, okay? You will in cardiology. What I need is if you suspect a PE, or if there's a patient that is PE suspect, you know what imaging to order based off of the criteria that you are given. What type of patient is it? Age, sex, pregnant, not pregnant, allergic to contrast, not allergic to contrast, good kidney function, bad kidney function, whatever the case may be, right? Wells criteria you will learn in cardiology, and you will have to calculate it all. So that's why I just circled on that chart the CTPA versus ventilation perfusion thing, because that's a whole Wells criteria chart. I just want you to know that section of it, of like when do I do a CTPA versus a ventilation perfusion scan. I do not want you to calculate the low, medium, high risk for Wells criteria, because we didn't learn that or cover it, but you will in cardiology. But there's just not a good, like all the Wells criteria algorithms have the whole thing in there, so it doesn't really do that. So no, you don't have to calculate it. You just need to know what imaging to order if you're concerned about a PE based off of the information that is presented. Because some of it was ultrasound, some of it was CT, some of it was ventilation perfusion scan, just depending on multiple factors. Yes?
So looking at like the aortic aneurysm versus like the dissection.
Yeah, let me get off this red slide so I don't keep burning people's eyes. Okay.
So, you know, very similar location, you know.
Yeah.
Right there.
Yeah.
Large, you know, a lot going on.
Mm-hmm.
So if I'm trying to differentiate between those two, like should I lean more on like the ripping sensation that's more common to dissection as opposed to like asymptomatic, or?
You got it right there.
Yeah.
You just talked about it. So most dissections lead from aneurysms that have been going on for long, and that pressure eventually creates that dissection. Most aneurysms are asymptomatic, as the slide says, like 85% of them are asymptomatic, right? So when you have a patient coming in, and if you have an x-ray, and you're concerned about it, you just have the x-ray, and you have some of that stuff, and you look at the vignette, you're like, gosh, I can see the large aorta on both sides, I definitely can see that. Is this aneurysm versus dissection? What's the symptoms? What's the patient reporting? Because, go ahead.
I have a question.
About that or something else?
Yes.
Okay, go ahead.
Dissection versus uncoiling, is it the same thing?
So the uncoiling is a description of the aorta uncoiling, right? Dissection is a diagnosis of what's happening with the patient. So an aneurysm causes uncoiling of the aorta, right? An aortic aneurysm, which can then lead to a dissection. So the uncoiling aorta is a descriptor on the x-ray. I can see the ascending coming up, I can see the arch, I can see the descending coming down. I have that widened mediastinum because of both sides of the aorta, and that's my uncoiling of the aorta. The next question becomes, why? What's going on? Is this just an aneurysm? Is this a dissection? What's the story? And if I'm trying to distinguish between those two, is the patient having that tearing, ripping back pain, right? Back or chest pain. Because what that is that's that one layer of the inner part of the aorta, of the vessel wall, that got, laceration's a bad word for it, right? Because there's nothing sharp in there, but from the pressure, kind of got some blood in there and it started to peel away, and now the blood pressure is pushing the blood in between those two layers, and it's just continuing to rip and dissect and peel away from that pressure, and that's what causes that tearing back pain. That's how you can distinguish without a CT if you suspect aneurysm versus dissection. But then what your next step is going to be order that CT with contrast, right, to look at the aorta And then when you go back and look at those slides, we had two of them. We had the large aorta where it was just all bright white and circular or oval shaped and all within the one tubular structure, which is the aorta. And then you had the one that had it kind of bright white in the center, but then on the outer edges kind of had a little bit of a brighter gray kind of surrounding the aorta. That was that dissection because some of that contrasted blood was getting in between those two layers. And the CT will definitively diagnose that, but your clinical suspicion is going to be based off of that tearing, ripping pain between the two. Sir?
And just to keep hitting on that, that would be that pathology of the symptoms with your definition, like, okay, this aorta is uncoiling because of the aneurysm as opposed to hypertensive cardiovascular.
What's going on with the patient? Yeah, right? Because again, right, it depends. You can have long-standing hypertensive cardiovascular disease, which doesn't get treated, and then leads to an aortic aneurysm, right? These are all things that are all interconnected. So then, aortic aneurysm and hypertensive cardiovascular disease are two separate diagnoses. One can lead to the other. You can have an aneurysm without hypertensive cardiovascular disease. You can have hypertension without having an aneurysm, but you can also have both at the same time, right? So I guess what I'm getting at is if you have an image on there in that aspect, and you have a large left ventricle, and you have the large aorta, right? There's no way for me to necessarily ask you a question and give you both the choices of aortic aneurysm and hypertensive cardiovascular disorder in this course and have you be able to pick out between the two. Because the imaging, they both are probably going to look the same. And there's really not a whole lot on symptoms for the two of them because hypertension is asymptomatic most of the time as well as the aneurysm is. However, I could have both of those answers and dissection and give you the tearing, ripping back pain, and now all of a sudden dissection becomes the most correct because of the symptom that I gave you, right? So in this course, I can't really do that because they look very similar on X-ray. You will learn more next semester on how to further distinguish between those two things. What else? Let's see. No, go ahead.
In terms of for aneurysm and dissection, we're going to use CT with contrast?
Yes. CT with contrast for both of those because I need to properly evaluate the vasculature, which is primarily in this case the aorta, which I can't do without contrast. Yep. Once I know they have that distinction between the two, right? So you can do an ultrasound to look for aneurysm, but you can't distinguish between dissection and aneurysm without the CT technically.
And generally, the aneurysm could be an asymptomatic patient versus dissection. You can get that very
Yeah. In general, yes. And your aneurysm patient may be symptomatic, right? They're not always going to be asymptomatic, but it's that very descriptive type of pain that makes you think dissection. Having an achy pain with an aneurysm, I'm not thinking dissection at this point. It is described just like that because of what's happening. Yeah?
Just for this test, are we thinking unstable dissection? We're going to have to decide between going to CT or going to surgery?
We haven't really talked about treatments.
Right.
So no. Yeah, no, it's good to ask, right? So the question was, hey, we have to decide, hey, great, we got an unstable dissection. Do we send them to CT? Do we send them to surgery? What are we doing? We're not getting into any of that stuff. That'd be more emergency med type thing, right? Right now, my goal is to make sure you guys know how to have a suspicion, know how to appropriately evaluate that suspicion. You'll get into what to do with these patients junior and senior semester. Yeah.
Talking about Dressler syndrome.
Dressler syndrome. Yeah, can you remind me what slide deck and slide that is?
Lecture 3, slide 42.
Yes. Thank you. I just realized that. I was like, you delete this. I'm just kidding. You're good. Dressler syndrome. Okay? What's your question?
I was looking at slide 42 because I was wondering, does that cause the fusion or is that the result of the left side infusion?
Dressler syndrome in general?
Yes.
So Dressler syndrome doesn't cause or anything. Dressler syndrome is the general diagnosis for somebody who is post-MI, has pleural effusion, has these things basically. That's what Dressler syndrome is. So that's what they call it, because it's immune response after heart damage, right? So, where are we at here? Yeah. So what this is what you're looking at is it's just the diagnosis for somebody who is post-MI or post-pericardiotomy syndrome. 2 to 3 weeks afterwards, they have fever, chest pain, effusion, and a pericardial friction rub often noted. If they have those things that match up, it's Dressler syndrome.
From the left side.
Correct. Yes, it's a left-sided effusion, yeah. So Dressler syndrome, again, it's just the name of, I got a left-sided effusion, because there's the effusion right there. On top of the fact that they're post-MI, they're having a friction rub, I got all these things. We're no longer just going to be like, oh, you have an effusion and a pericardial, maybe some pericarditis. Nope, you have Dressler syndrome. Right? And so that's what this one is. There's certain diagnoses that cardiologists get really antsy and excited about. Dressler syndrome is one of them. Yeah.
I was curious for the imaging for Dressler syndrome. Are they always going to order it like overexposed, or
No,
you can't really
no.
see the ribs?
No. It's just the nature of that picture. You don't, and that's the thing, is like you don't necessarily, yeah, I don't really like it either, but you don't order like a certain level of exposure on your x-ray, you're just going to get the x-ray, right? It just, this one just happens to be overexposed to show, really it's just showing the effusion, right? Showing the effusion on this one, and then you have the effusion along with pericardial friction rub, post-MI, really post-MI and the effusion, you should be thinking Dressler syndrome. Yes, sir.
So, looking at the Crohn's disease, like habit is.
Yeah.
Like I understand typically like the right side, like small bowel. That's one way to like differentiate between the ulcerative colitis. But like the only image we've really got is like the string sign.
Yep.
And then there's like the list of all the other findings on imaging. Like, do you have any examples of those, or is it just like string signs the one that's like so? It stands out so much, that's the one that you want to.
String sign is pretty pathognomic of that Crohn's disease on imaging. That's going to be the one. Even with some of those other things, if I didn't have that string sign, I don't know that I would be confident enough with just imaging to diagnose the Crohn's. That's going to be my one that I'm going to hang my hat on. Yeah. Typically in that terminal ileum area. Yeah. Yes. Mm-hmm.
But so the only thing that we're going to be able to help us differentiate is to what we see on the x-rays, like her being on between interstitial rather than the alveolar.
So, I guess I'm trying to figure out what you're asking, because
Like if we have to differentiate both from the alveolar or interstitial, the only thing that's like you're.
so the difference between alveolar and interstitial edema is going to be in the image, right? The alveolar edema is that fluffy, patchy kind of edema, and the interstitial edema is going to be your more linear kind of tract edema, right? And the reason I'm kind of trying to have you quantify just a little bit more is because both of those are stages and stepwise towards CHF. It's not like distinguishing CHF from those things. Those things is a part of CHF, congestive heart failure, and it just depends on how severe it is, which you guys don't need to know the stages of how severe it is. So it's just more kind of, I would say, focus more on knowing the difference between interstitial edema and alveolar edema and what they look like, as opposed to trying to figure out, well, is this or is this CHF? Because that's kind of a symptom of CHF. We'll be right with you. He had his hand up. Covered it? Perfect. Okay, what do you got?
Mine's about that because nodular interstitial edema looks pretty freaking similar to alveolar. Like the nodules are not super well defined. Like, it's like a 3
Yeah, let's see what we can look at it.
Project 3, slide 18.
All right. I think I'm in 3 right now.
Yes.
Okay.
That looks pretty fluffy and catchy, but it's interstitial, not.
It is, but I can make out little circles here, 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 right? Here. And then, but if I go into my, do I?
Yeah, slide. 6.
Thank you. Right? I have nothing that really, I can't even make out any kind of defined circles on that. And look at how much more kind of diverse and stressed it is.
So
I wouldn't,
towards the right page.
yeah, I wouldn't get so hung up on the nodular interstitial edema type thing, right? The reticular, the nodular, right? Difference between reticular and the nodular, sure, but as far as the nodular, if I'm giving you between these two things, it'll be clearly an alveolar edema versus an interstitial edema. Okay, it's not going to be a close-up like that one picture is, because if you notice like how close up those ones are, in order for me to make those little round ones stand out, I had to get one that was like zoomed in and close up, right? Whereas this is very, very generalized here in this area. So I wouldn't get too hung up on that so much. I say interstitial, focus on the reticular portion of the lines as far as distinguishing that between the alveolar edema. Right, let's talk about CHF for a second. CHF was the first thing we talked about because it was the culminating disease process for all of these other things we discussed if they go untreated and they continue to get worse. So yes, all of these things can lead to congestive heart failure. All of them, right? What stages are we in? Well, we saw that. We're not going to focus on the stages, but knowing that you can have interstitial edema, which after a while can lead to the alveolar edema, which is going to happen. And then after a while, you're going to have more leakage, and you're going to have parabronchial cuffing. Then really towards the end, you're going to have that cephalization, right? Because now we're getting to the point where everything's backing up. It's a progressive process of all of these kinds of things. So how do I know if it's CHF versus some other condition that he's trying to ask for? Read the question and the answers first. Know what I'm trying to ask you. If CHF is in there, along with some of the other things, you're trying to figure it out. There were patient presentation things the patient says, things that lead you towards thinking CHF when they're coming and they're presenting with their symptoms versus something else. Anybody remember what that one in particular one was? Paroxysmal nocturnal dyspnea, right? But then also understanding what the layman's terms for that are. Patient's not going to come in and say, I'm having some paroxysmal nocturnal dyspnea. I'm sleeping in a recliner, or I notice I'm having to sleep with more pillows behind my back, so I need to be propped up because he needs that gravity to help drain that fluid down because of all the pressure that's happening. When he lays at night, it just kind of lays across, right? So there are things in the slides that will help you distinguish that, okay? I know it's a radiology course, and a lot of block 1 was recognize the abnormalities on the radiological imaging. That's true in this as well, but this block is not possible without understanding the pathophysiology behind the disease processes on the foundational level I've given you, right? And associating them with patient history and patient symptoms, because everything looks so similar. And on top of that, it is much harder for me to find chest x-rays because they're sick with just one abnormality on them. It is difficult. So like when I'm writing these tests, I have to make sure they're worded in a certain way to where I don't have answer choices that are some of the other abnormalities that are on there, so that way they can't be multiple correct answers. And sometimes that is the fact that, well, hey, yeah, there is this on there as well, but when you go back to the patient vignette, they don't have this, or they do have this. And that's what drives you towards the most correct or the most possible answer at this point in time. So understanding those nuances of the differences of either the symptoms or the history or the patient demographics. Guys, like dilated cardiomyopathy, hypertrophic cardiomyopathy, they look the same on x-ray. What kind of patient do I have? What am I more concerned about between the two? That's what I'm going towards. right? Guess what? That's going to look the same as hypertensive cardiovascular disorder with left ventricular hypertrophy. It's all going to look the same. What kind of patient do I have? What am I trying to figure out? What else? Yes, sir.
There was troponin associated with fluid feeding, but there was on their side, it was worse for them.
Yes, correct. And so when they lay on the affected side, right, is the tropopnea because the fluid kind of pans out in that aspect. So that's where like I have a hard time, but when I switch over to my right side, I'm doing pretty good, right? That would be a pleural effusion. Yep. Remember, there are certain pleural effusions that move with positions, and there are certain ones that don't move with positioning. Right? Remember that? Loculated ones, things along those lines, separate those out. Remember what pulls and what pushes mediastinal structures. Know your lobes. Yeah, go ahead.
Could you briefly summarize the different types of atelectasis?
Briefly summarize? That's like a whole lecture. No, I don't want to do that either. Let me put it this way. Which ones are confusing you?
I guess the compressive versus the round distribution. I'm gonna read this right now.
Sure.
I'm not sure.
Okay, if you want to see me after, we can go over it after.
Okay.
Happy to do that. I will be here. I'm not going anywhere today, guys. I got too much work to do for the boss, anyways. So the atelectasis is I still got to figure out how to say that. The differences, right? In general, go over that slide with the different ones. I believe there are some of them that have certain words that are bolded, but it's in white, right? To help you kind of distinguish between those ones. Use that. Anything more than what's in that slide to distinguish between them, there's nothing more I need you to really know, right? And I can't ask you anything more involved than what's on there because this slide is your study sources for here in phase 1. So, yeah, I would just, you know what slide that is? Let me see if I pull it up.
27, deck 3.
There's a lovely deck 3 today.
2 and 3 is hard.
All right. So, let's take a look here. So look at your causes. All right. So if I got, let's go with the subsegmental, right? It's going to be the patients who are splinting, not taking a deep breath in, such as post-operative patients, right? It's going to likely be a subsegmental. Your compressive atelectasis, look at your causes there. What's happening? Something is compressing on the lung tissue, causing it to cause an atelectasis. And what the heck could compress? Pleural effusions, pneumothoraces, space-occupying lesion. Big fancy word for a tumor or mass, right? It's not supposed to be there because it's the reason you have the atelectasis is something is pushing on it, causing it to collapse on itself. Your round atelectasis, typically in the peripheral lung, examples, asbestos exposure or tuberculosis, i.e., there should also probably be a cavity somewhere in there as well, right? So it's the cavitary abnormality, which is round, which can then cause an atelectasis in that area. And your obstruction being the most common, it's the most common, right? There's not really, something's obstructing it. So if you think about it this way, right, most common, why do we say foreign body? Well, let's say I inhale a piece of food, or a little kid inhaled a marble, right? And it settles down in that bronchi, and it obstructs air from getting through to that point. And so everything afterwards, there's no air. Once all the air is gone, there's no more air keeping that airway open, so then it collapses on itself to cause atelectasis. That's kind of the description of the obstructive in that aspect, usually from a foreign body. And those are kind of your cliff notes. And really, we haven't really looked at a whole lot of different ones on x-ray to kind of see what the differences are and kind of what they look like and to pull them out. Is to know, like, what are your most common types of atelectasis and what types of patients are you going to see those in. Does that help?
Yes, sir.
Okay. Don't get too in the weeds with this. Right? Stay on the lily pads. We'll let Dr. DeBoer, Dr. Cola, and all the people get you guys in the weeds next semester.
Just to
Yeah.
question on that, so like the Fisher lines on atelectasis, like we're not gonna be like identifying where the specific atelectasis is based on the Fisher line. You have like lateral views with atelectasis and fissures who are pointing towards the island.
So if I give you both the PA and the lateral, you should be able to identify the location of the atelectasis, just like the pneumonia, to be able to give you both of those. So it's possible. I don't know. I've had questions like that before, right? But that's more recognizing that it's an atelectasis and then utilizing your knowledge of PA versus lateral chest X-ray to figure out what lobe is that in. Ma'am.
So, between the discussion regarding locular diffusions, hydrogen thorax, and diffusion, I don't remember
That's the loculated effusions. The fluid does not move with position.
Right, so hydrogen thorax, sorry.
That's not me.
Would move.
Yes, because a hydropneumothorax is basically just both fluid, likely blood, but we don't know that, right, on x-ray, fluid and air in the pleural space. It's not held into one area, so if you light them down or move them to the side, it would definitely move with position. But your loculated effusions will not. Sir.
Why does your hydropneumothorax not have wings beside the black line?
Because the air is helping kind of keep that flat out when you have both of them in there. The other ones are just sitting in there, and it's a pleural space. It's just the way it kind of fills up in the lung. It's just the way that it looks. But when you have the pneumothorax as well, the air is putting equal amount of pressure as the fluid is, so it just kind of flattens it out. Yeah.
Laminar effusions also don't move.
Correct. Laminar effusions also don't move. The difference is that I can't put both of those choices on the test for you. I really don't want to go there, right? And that's, yep, really don't want to go there. That would take me off of the lily pads and we'd be diving deep under. We don't want to go there. What else? Yes, sir.
I just had a quick question about the FAST exams.
FAST exams.
Or when in the patient vignette, is it going to tell us you got a FAST exam of the liver area or the right lower quadrant or the right upper quadrant? What information we're going to be given besides just a picture of the ultrasound? Or what?
I don't know. I mean, I do know, but I can't tell you. What's your concern?
My concern is we just get an ultrasound. It's what organ is this? And it's it's two circles.
So like a right upper quadrant versus a left upper quadrant.
Okay, so you're concerned. So if I want to ask you an anatomy question, I have a lot better images that I could do than a FAST exam.
Okay.
Right? If I give you a FAST exam question, I need you to know normal versus abnormal. That is what is mega important when it comes to a FAST exam. If I want to ask you liver versus spleen, I got plenty of other pictures I can do that's not a FAST exam to make you pick out an anatomy question.
I was making sure because the livers and the kidney and then the spleen and the kidney look kind of similar, so I was just trying to.
You mean the liver and the spleen look similar?
To the when they're paired up
to each
against
other.
the kidney,
Yeah.
to each other compared up.
They are, and they are, right? I mean that's why we didn't really. How are you going to know that? Well, easy. You're the one doing the FAST exam, so you're going to know what you're looking at, right? So should you on a FAST exam be able to figure out the anatomy of spleen versus kidney? Yeah. Liver versus kidney? Yeah, they look different. But as far as is it right upper quadrant or left upper quadrant, I don't care for this because we haven't really covered that. If I want to ask you anatomy, I won't be using a FAST exam in that aspect. So I appreciate that on that ultrasound, the density of the liver and the spleen look very similar. So how am I supposed to know where I'm at? If it's a normal FAST exam, I don't care. If it's abnormal, I don't care. It's abnormal because now we know we have internal bleeding, right? So focus on that part of it as opposed to telling the dystrophy right and left upper quadrant.
Sure.
guys always word questions in a weird way sometimes. Like, are you just trying to find out if there's a question on the test, or do you you're actually confused about a topic? Both. I know, the answer is both. It was both when I was here too, and it never worked, but the answer was both.
It had like 50 slides.
All right, before we continue, I'm going to give a plea for any of you who you don't have to do this, but after this is over, if any of you happen to have spouses who are available tomorrow morning who are willing to share their experience so far with the new incoming freshman spouses, let me know. Because I'm the new incoming class advisor. We're having that tomorrow at 9. So, not mandatory, but if anybody has anybody who's been through it for the past 8 months is like, yeah, I'll go warn these suckers what they're about to go through, right? And answer real questions, and also like things to do with kids in the area, you know, stuff like that. I'll give you the details if you're interested, or if you have somebody who's interested, let me know.
I have the details too, if anyone needs them.
Yeah. So, there's my shameless plug as I start taking care of 78 young PA students and their families. So I think I've hit most of the big points that I think, and honestly, you guys asked most of the big points I was going to try to hit anyways. I think you guys are locked in. For those of you that are here, for those of you who don't here, I don't know what you think, but hopefully this was helpful. I think you guys are pretty locked in. You have a really good understanding of kind of what you're looking at. The questions you guys have been asking are good questions. They're not like foundational level questions. You're like thinking on the level you need to be. Just remember to stay out of the weeds, right? Don't get too into the images too much until you know you need to get to that point. If you don't see it, it's probably not there. Sometimes you might not see something that is there, but use all your context clues, right? Like that subcutaneous emphysema sometimes, like the patient presentation, like the patient history, like the age and sex of the patient. Pay attention to the little things, because most of the time through this program going forward in junior and senior semester, the reason you guys are going to get things wrong is because you missed something little in that vignette that you didn't pick up on or you skimmed over and you're like, oh my goodness. So, any last alibis or questions for those that are hanging out? Go for it. Ah. So is that, it kind of, I mean, so the reason would be, hey, I have cardiomegaly, and the reason is the patient has pectus excavatum, right? And so that's kind of where you would end with that, if it was that bad, from an x-ray standpoint. Clinically, just for, S&G for you, like, that patient needs a surgical referral. Because if the pectus excavatum is so bad that it's compressing on the heart, causing cardiomegaly, they're going to have issues as they get older or as they start doing any kind of activity. So they're going to need a surgical referral because that's got to get fixed if it's actually causing cardiomegaly. Most of your patients, it won't be causing that, but that's just as correct. It's not a normal x-ray because I have cardiomegaly, right? Once I have cardiomegaly, it's not a normal x-ray anymore. Unless it's an AP, and I told you it's an AP that's just slightly larger. But I probably won't be asking you to pull out cardiomegaly on an AP. As I know I'm not going to be asking you to pull out cardiomegaly on an AP chest x-ray. I know I'm not. Yeah, good stuff. Anything else?
So with the large valve obstruction, if they overcome the overleaking valve, we still call it like distance, so it's going to be a large valve obstruction versus a small valve obstruction?
I don't think I've ever seen an obstruction at the juncture of the small bowel, large bowel, like where the actual obstruction is.
Okay, so still
Yes. Yeah.
I'm kind of confused about the generalized areas, having both of them. Like somewhere in here, I was reading about how if it backs up that much and goes past that.
Correct. So you can have a large bowel obstruction that is giving you large bowel abnormalities and continues to back up into the small bowel as well. That's still a large bowel obstruction.
Okay.
Right? Don't get so hung up on like, well, what if the obstruction is right at the junction of the small bowel? Sure, call it large bowel. I don't know. I don't have one of those on the exam. Right? Because that would be really kind of hard to tell, right? If it's that bad. So what I would say in general is if you can't see any large bowel dilation at all, then you just call it a small bowel obstruction because that's all you can see. Because you're not going to know right where that ileocecal valve is on just an x-ray, right? And so you're going to base it off of what type of bowel do I see proximal right? And then, okay, I see large and small, so that's gonna be a large bowel obstruction, or I only see small, and boy, I'm pretty sure there were some very specific time frames and patient types that would lead you towards certain type of ileuses versus obstructions versus different bowels. That would be very beneficial to help you distinguish between those, at least for Thursday. After Thursday, it might be a little more convoluted, but for Thursday, that would be very helpful. I don't know why, just it's a good day. Thursday.
Good Thursday.
It's a good day. It's gonna be a good day. All right. Anything else? I will hang out here for those that were too afraid to kind of raise their hand here in the group, and then I should be available most of the day in my office. You have my number. Please send me